those two statements to be adduced in full, please. And what that means, Doctor, is that I don't need to ask you about every single line of those statements because they're already in evidence, but I want to ask you some questions on some particular topics. Can you please tell us what your qualifications are?
So I have a Bachelor's of Medicine and Surgery from Leeds University, and I'm a member of the Royal College of GPs, became a Fellow of the Royal College in 2013, and I'm a Senior Fellow of the Faculty of Medical Leadership and Management.
And what's your role at PPG?
I'm the National Medical Director for Health and Justice, which means that I look after the sort of clinical strategy and oversight of the secure environments that we operate in.
Thank you. We heard from your colleague, Mr. Wells, yesterday, and that he said that PPG effectively didn't have much experience of working in IRCs prior to the Gatwick IRCs. Is that right?
Yeah, so we were in Campsfield House for a couple of years before it closed. That was our first, certainly my first experience of the IRC environment. We also provided healthcare in the Verne, but that quickly re-rolled to a prison shortly after we took over.
And so most of the company's prior and current experience is mainly in the provision of healthcare in prisons, is that right?
That's right. So we operate in 48 establishments at the moment, 47 of which are prisons.
Thank you. You'd accept, though, as he did, that the IRC operates as a different detention environment to a prison, primarily because detainees are not in an IRC by order of a court, but rather because of an administrative power being exercised by the Home Office. Is that right?
That's right, yes.
And there's also in IRCs no time limit to detention. Is that your understanding?
That's my understanding.
The role of healthcare then in an IRC is not just to provide primary healthcare, but to provide important clinical safeguards which identify who is vulnerable to harm in detention and notify the Home Office of those people so that their continued detention can be promptly reviewed and that they might be considered for removal from detention. Is that right?
That's certainly one of the roles of healthcare within the environment.
I just want to look then at the safeguards that we've spent a considerable amount of time on in this inquiry under Rules 34 and 35. At paragraph 4 of your first witness statement, you acknowledge that Rule 34 is clear that all residents should get an assessment within 24 hours and that there is an induction for all staff about the importance of Rule 34. Is that right?
That's currently the position.
At paragraph 5, you raised the issue of the high rate of did not attend to Rule 34 appointments and that you plan to train staff to talk to detainees about the importance and the purpose of Rule 34 and to encourage them to attend those appointments. Is that right?
Yes.
So that training hasn't yet been delivered, is that correct?
No, that's correct. So,
the intention is to complete that training by the end of May of this year, is that right?
Yeah, so the reception screening training is being adapted for the immigration removal environment, and that will include information around Rule 34, the importance of it and the reasons for it, to try and help staff to encourage people to know what their rights are and to attend for those appointments.
Yes, because Rule 34 is an important statutory mechanism that's intended to and should lead to directly a Rule 35 report at the earliest opportunity to identify a person who possibly shouldn't be in detention because they're an adult at risk. Would you agree?
So I think there's a little too much of a direct relationship there, but yes, in circumstances where somebody is unfit for detention, a Rule 34 should lead to a Rule 35 assessment, but not necessarily for everybody.
Staff it appears, don't currently seem to be explaining to detainees who decline or refuse the Rule 34 appointment its importance, do they? And that's clearly a training need you've identified.
I would agree, yes.
They're not, or they certainly haven't been up to date, informing detainees that they have a right to a full medical examination, both physical and mental, including the possible consideration of a Rule 35 report at that stage, have they?
That's my understanding.
And so in that way, the rules the staff haven't been explaining that the rules are a safeguard to identify vulnerable people to the Home Office so that their detention can be reviewed, have they to date?
I'm not even sure that they've understood that themselves, let alone communicated that.
Yes, and it's clearly important that that information should be given to detainees, isn't it?
Agreed.
Because otherwise any refusal of that appointment or decision that they don't want to attend it is not a properly informed one. Would you agree? Have PPG taken any steps to date to reiterate that to staff conducting that reception health screening in advance of the training being rolled out by the end of May?
Other than informal conversations, no. I think it's fair to say that we've been on a learning curve as well. I think the inquiry's actually been very helpful from my perspective to understand in a great deal more depth than I otherwise would have done the requirements around this. But I think my assessment from visiting the site and from listening to some of the evidence is the purpose of Rule 34 and Rule 35 have got lost in the process. So people are focusing on getting the process, ticking the boxes almost, without remembering why it's there and that it's actually a safeguarding process. And that's why I think, as my colleague said yesterday, we've decided to take a longer view on how we address this issue rather than a kind of quick fix solution.
Yes, but we'll perhaps come to that in more detail in a moment. Sure. But what monitoring is there of the quality of that reception health screening process currently?
I don't think I could point to anything that gives you much more than activity data. So when somebody undertakes a reception screening, it's recorded on the clinical record system, System 1, and it's done via a template. So we know that it covers a range of topics that have been pre-agreed, that needs to be explored at each of those reception screening. But it doesn't tell us much about the quality of the conversation that happened at that point.
Does PPG intend to take any steps in the future to monitor the quality of that process?
It's quite a difficult thing to do, to find a quality measure that works. So I think that will be something that will be subject to some audit and conversations at the quality assurance meeting. There's things you can measure, you can pull out the record system, but it still only really tells you an activity has happened, not what the quality of that conversation has been.
So that's something PPG is considering how to do?
Absolutely. I just haven't got an answer for you yet.
The inquiry has heard a considerable amount of evidence about the operation of Rules 34 and 35, and in particular, the inquiry's heard some evidence from Sandra Calver, who was in 2017 and still is the head of healthcare in Brookhouse. Did you listen to her evidence?
I didn't see her evidence, but I have read some of the transcripts and I've read a summary of her evidence.
She gave some evidence that GP appointments carried out within the first 24 hours are now 10 minutes long. In 2017, they were 5 minutes long. But that's not enough time to do a Rule 34 compliant medical examination because it requires a full physical and mental examination. Were you aware of that?
Not until I'd heard the evidence, particularly. But it doesn't surprise me either, because GP appointments in the community are all 10 minutes long. So it would stand to reason that is translated into the environment as a standard.
And Dr. Ozarali gave some evidence that it wasn't possible to do the sort of physical and mental state examination required at that initial GP appointment, and he described it as almost like triage. Were you aware of that?
That's all you can do really in 10 minutes, unless you're dealing with a specific issue that somebody presents with.
Did you watch Dr. Ozarali's evidence?
I watched most of it.
He gave evidence that if there was a disclosure, for example, of torture in that initial appointment or something else which raised a concern, which meant there should be consideration of a Rule 35 report, instead of completing a report immediately at that time when the disclosure or concern was raised, a further longer appointment was made at a later time for a further Rule 35 assessment, and that built in delays. Were you aware of that?
Not so specifically, but I guess I would have assumed that was the process. Yeah.
Certainly you're aware of that now as a result of his evidence. So whilst you're arranging GP appointments within 24 hours, that appointment isn't achieving the purpose of Rule 34, is it? Would you accept that?
No. I don't think it's quite as clear-cut when I read the Rule 35 guidance, but I appreciate that it does ask for full physical and mental assessment, so it won't achieve that. And I don't think it can achieve a decision at the end of that period about whether somebody is fit for detention.
Or indeed the completion of the report?
Or the completion of the report, no.
So it's not feasible within the way things are currently arranged in terms of 10-minute appointments. Would you agree that more resources are needed to comply with the requirements of Rule 34 than are currently allocated?
I don't know yet. And that's something that I'm keen to explore with the teams to see if we can do things differently to understand how to make that system work effectively.
Dr. Uzerali also said that he would argue that it would almost be more sensible to consider vulnerabilities before the detention was even in place, so that indicators of torture and pre-existing mental illness are identified before the person is even detained in the first place. Would you agree with that?
And that would make complete sense. Yeah.
So improved medical screening by the Home Office prior to detention to identify vulnerabilities and decision making on those unsuitable for detention under the adults at risk policy would most effectively reduce the pressures on the Rule 34 and 35 process, wouldn't it?
Agreed. It makes no sense to send people to a place that's unsuitable for them.
If there was better screening, filtering out vulnerable people before detention, the rules would be less likely to be breached, wouldn't they, in detention, because there would simply be less people requiring a Rule 35 report.
Agreed.
Do you think it's likely that without such screening prior to detention, the rules will continue to be breached?
Again, I don't know the answer to that yet because I'm keen to explore what we can do effectively with the resources that we've got, but I think it is likely that it will continue to be breached, particularly as the numbers ramp up in Brookhouse. At the moment, my understanding is the numbers are quite low compared to where they may be in the future, and obviously that's a highly variable number.
Yes.
But the more people that are in there, the more likely it is that those timescales will be breached.
Yes. I think there are 169 detainees in Brookhouse at present. Are you aware of that?
Just from this morning's
Yes,
evidence,
exactly. At paragraph 7 of your witness statement, you say that staff have been made aware through induction of the process for obtaining a Rule 35 report, but we know from the evidence of both Dr. Uzerali and Sandra Calver that they're not in fact being completed as a result of those initial appointments within 24 hours, because that appointment isn't an effective Rule 34 appointment. Is that your understanding of the current situation?
My understanding at the moment is that the Rule 35 process is failing at various points through the system, one of which is from reception through to that first opportunity to assess somebody.
So it's failing at that initial stage when someone comes into detention, would you agree?
At times. Obviously, sometimes it works, but other times it doesn't.
And as we've established, that Rule 34 is particularly important to identify vulnerability at the outset of detention and inform the Home Office through Rule 35 because of the absence of prior screening. Would you agree with that?
Okay, let me just untangle that a second. So if people don't come to us, that makes more sense.
But if they
are,
because they're not being screened,
it's important to pick up their vulnerabilities at that point in order to inform a Rule 35 assessment, in order to inform a Home Office decision about the suitability of detention.
Yes, at the very earliest opportunity of them coming into detention.
Yes.
Your staff don't appear to be doing that on the ground currently. Do you think that's because of a lack of understanding of the purpose of Rule 34 and 35 working together?
I think there might be a number of reasons for that. One may be a lack of understanding. I think showing somebody a piece of paper about what to do doesn't necessarily help them to understand it properly, hence the plan for training. But I think, again, my reading of what's happening and from the visits that I've done, there is a great deal of custom and practice, which is in Gatwick, but is also prevalent across other parts of the immigration removal estate, as far as I understand it. And so some of what we need to do is to challenge custom and practice and the interpretation of the rules that have happened to date.
Yes. And even if your staff understand what needs to be done under Rule 34, working together with Rule 35, at present they don't have sufficient resources to do it because the appointments are only 10 minutes long. Would you agree with that?
So I agree that the 10-minute appointments are not long enough to undertake a full physical and mental health examination. Whether the resources are there or not, I don't know still yet. We're looking at alternative models about how we better assess people on arrival in immigration removal centres. My personal view is that time spent up front is time well spent. Even if people remain in detention, having a greater understanding of their physical and mental health needs has got to be of benefit in terms of planning for their care and making sure that we deliver care that meets their needs. So by adopting a person-centred approach on arrival, we can do a better job. But I think that works best when we've got a multidisciplinary team as part of that assessment, because then we have a wider understanding that can inform that assessment by the doctor under Rule 35, acknowledging that it is the GP that needs to complete the assessment. But that broader multidisciplinary assessment, so I keep hitting the microphone, from the mental health team, from the nursing staff that are involved, can actually give a much more holistic picture of somebody's needs and vulnerabilities than one single appointment will do with a GP.
Yes, agreed in relation to providing any care or meeting their needs in detention, but of course the importance of the safeguards is to notify the Home Office so that they're required to undertake a review of their detention, potentially to route those vulnerable people out of detention. That's right, isn't it?
I agree, but what I would say is this, that when people come into an environment, a secure environment, whether that be prison or immigration removal, it's an overwhelming and frightening experience. People don't know what the rules of engagement are. They don't know if they're going to be safe. There's a number of things that will be affecting them at that point. So whether you get a full picture of their vulnerabilities at that point is highly debatable. And a lot of it is about needing to build rapport and trust with people in order to enable them to be able to open up and trust you to be able to disclose their vulnerabilities. And so I'm not convinced that one single appointment will achieve that.
No, and of course Rule 35 isn't about one single appointment, is it? Exactly. It's an ongoing safeguard for whatever time the detainee is in detention. Agreed,
and this is why I say earlier that I think it's failing at multiple points, because I think it is being seen as a process to fulfil a task rather than a safeguarding process to look after people who are very vulnerable in the environment. And that's a culture shift that we have work to do on.
Is the Home Office aware of the allocation of resources of 10-minute appointments for Rule 34 appointments, so far as you know?
I don't know. I would assume so, but I don't know.
Is the allocation of resources something that PPG is going to be raising with the Home Office in this regard?
Once we have undertaken our exercise to look at the process and how it's working and begun to understand if there's any immediate changes that we can make that are straightforward without requiring further resources, then we'll definitely be including the Home Office and wider partnerships in our discussions about how we move forward.
At paragraph 8 of your first witness statement, you deal with training staff in the identification of conditions that may be detrimentally affected by detention. Does that training cover nurses only, or is that all staff?
No, I think it needs to be all staff, and the reception screening will largely be directed at nursing staff because it is them who see people when they first arrive. But the Rule 35 training we're developing will also be training doctors and more senior nurses to understand those conditions as well.
What is your understanding of the conditions that may be detrimentally affected by detention?
That is actually quite a difficult question to answer. I know what's in the adult at risk policy that is defined in terms of the vulnerabilities. So it may be a number of physical health conditions, and depends on the severity of those conditions. Frequent hospitalisation, for example, people who are elderly, people with mental ill health, people who are suicidal, and people who've been victims of trauma, torture, modern slavery, and
So is
on.
Yeah, is it intended that the training covers the adults at risk statutory guidance and the list of vulnerabilities there?
It certainly will do, but we've also reached out to the Faculty of Forensic and Legal Medicine for some help with that training as well, particularly in terms of the identification of symptoms and signs of trauma and torture, because they have a great deal of experience working in police custody and so on in terms of identification and giving opinion, which I understand has been one of the criticisms of the Rule 35 reports to date.
And is the training intended also to make clear that the adults at risk policy and those indicators of risk is connected to the use of the statutory safeguards under Rule 35?
Yes. I mean, it's quite interesting. I having read through the documentation, you have to look quite hard to see the connection between the adults at risk policy and the Rule 35 assessments, but it is there. But I think people do see them, there does seem to be a tendency to see them as completely separate,
Yes.
which is
and that's a
unfortunate.
concern.
It is a concern.
In relation to Rule 35, your colleague, Mr. Wells, said at paragraph 15 of his statement that provision is also made for 2 Rule 35 appointments per day over and above provision for primary care services and also separate to those Rule 34 10-minute appointments. Do you consider that to be sufficient provision?
I suspect not. That's something that we've inherited as practice, and I think, again, as the numbers ramp up within Brookhouse, that's going to have to be reviewed in order to make sure that we've got adequate provision.
Yes, you're aware that a high proportion of detainees in immigration detention have clinically significant levels of depression, PTSD and anxiety, is that right?
Of course.
And are you also aware that PTSD is frequently linked with a history of torture or other forms of serious ill treatment?
Yes.
Would you agree that detention is likely to precipitate significant deterioration of mental health in the majority of cases?
Yes. I mean, I don't know how you define majority, but yes, it's likely to precipitate a deterioration.
It can, for example, increase risk of self-harm and suicidal ideation.
It can.
And given the high prevalence of PTSD in people who are likely to have a history of torture or ill treatment in their past, who are likely to be harmed by being in detention, their prompt identification to the Home Office is essential so that their detention can be reviewed. Would you agree?
I would agree, but what I would say is that unless somebody has been previously diagnosed with PTSD, that is not quite as straightforward as it sounds.
Dr. Uzerali gave some evidence that there are currently delays in getting through the number of Rule 35s that need to be done. And there's a waiting list because only one Rule 35 is done a day. Would you accept that it's likely that whether it's one or two, there is going to need to be more resources allocated to the Rule 35 process, as you say, once numbers start to increase?
I think that's likely. It's something that we'll have to keep under close monitoring to understand what the waiting times are and be able to respond quickly if they increase.
Your role, as you've described at paragraph 1 of your witness statement, is governance and the quality of healthcare. Is that right?
Yes.
You say at paragraph 36 of your first witness statement that Rule 35 training was previously provided by the Home Office and NHS England, but this has not been offered over recent years. You say at paragraph 37 that currently Dr. PA Limited, your GP partner, provide new GPs with a slide set about the Rule 35 process and an example of a good Rule 35 submission, and this is discussed with the GP to ensure understanding of the process. On what basis did you assess the example provided was a good Rule 35 submission?
So I didn't, and it was a question that I asked myself when I went into Brookhouse as to who's defined what a good one looks like, and I haven't actually had a satisfactory answer to that. I'm not sure. I think there's been some evidence given as well about oversight of the quality of Rule 35 reports. There doesn't seem to be any standard. And with the training, I wasn't around when the training was provided by NHS England in the Home Office. It's something I've had reported to me, but it certainly hasn't been repeated. And so understanding expectations is something that I think has been difficult for GPs working in this environment. It's one of the reasons why we've decided to take the approach that we have to look at what good looks like. And to try and understand how we then train people to do that, not just as a one-off, but as a regular refresher in terms of doing high-quality Rule 35 reports.
You aware that Dr. Hard looked at over 80 Rule 35 reports from the relevant period in 2017 and found that in 75% roughly of the cases that they were inadequate, in particular because there'd been no assessment or recording of the continued impact of detention.
Yes, I read his report and listened to some of his evidence on that, and that's one of the reasons why we've reached out to the Faculty of Forensic and Legal Medicine to help us with increasing confidence in the GPs in giving an opinion on precisely that.
Yes, because those reports that Dr. Hard looked at were primarily from Dr. Uzerali and Dr. Chowdhury, who of course are still working in Brookhouse and who are training other GPs in Rule 35. That's of concern, isn't it, given Dr. Hard's view about the quality of those reports?
It's certainly something that has stimulated us to look at the whole process and understand how we get better training and understanding in the GPs working there.
Some evidence was given from Medical Justice of the types of deficiencies that they've seen in their casework in relation to Rule 35 reports and their quality. And Dr. Hard, in his live evidence, agreed that there were various different deficiencies, as they described, in the majority of the reports he'd seen, sometimes because of the misapplication of the threshold for a report, sometimes the failure to identify the mental health consequences of torture, as I've mentioned, a failure to consider the impact of detention despite the fact that the form directs the doctor to do so, and a lack of recognition that having a history of torture makes someone vulnerable to harm in detention. Dr. Hard was of the view in his evidence that in the circumstances where Dr. Uzerali's training was likely to have been inadequate and these various deficiencies were in so many of the reports, it wasn't acceptable for him to be training other GPs. Do you have any comment upon that, given that it seems he still is training other GPs?
I think there is no training out there for Rule 35 assessments, certainly none that we've been able to find. So people have had to make do and produce something themselves. I think it's a deficiency generally across the immigration removal estate and something that we're keen to address by developing some training. So yes, whilst it's a concern, it is something that we're addressing at the moment, but I don't think it's peculiar to Gatwick.
Has the deficiencies in those reports, in particular that they for the most part failed to consider the impact of detention, been taken up with Dr. Uzerali to date?
I haven't had a conversation with him about it.
Why not? Because I appreciate the lack of training out there, but isn't it a relatively straightforward thing to bring up with him that, Doctor, you must, as the form directs, consider and comment upon the impact of detention on the detainee when you complete these reports?
Yeah, I think that's a fair comment. I think what I would say is that I don't have that much direct contact with the site, and so the Rule 35 pathway workshop that was discussed yesterday, I've been seeing as my opportunity to sit down with them. We have just taken over Heathrow Immigration Removal Centre as well, and so we'll be drawing the two teams together to do some looking at what works well and what doesn't work well and sharing some good practice. There's my understanding so far, and it's limited of Heathrow because, say, we've literally just taken that, but that there are more Rule 35-2 reports done at Heathrow than there are at Gatwick, for example. And so there's clearly a different understanding of the process. And by bringing the two teams together, we can understand why there's difference and why there's difference in practice there.
In the circumstances, though, I appreciate what you've said about the workshop and the opportunity to sit down and talk about these issues, but isn't there an urgent need to look at the quality of the reports that Dr. Uzerali and Dr. Chowdhury are actually completing now?
So I understand where you're coming from with that, and you know, I think you've asked the question of my colleague yesterday, are there likely to be people in detention who shouldn't be there if they'd had a better quality Rule 35 report done? I completely acknowledge the role that we have as a healthcare provider in making that system work to the best of our ability. But just to point out, we're not in control of the final decision about that. It is a recommendation and a report that's done on healthcare. So we want to do that as well as we possibly can. We had some debate about how quickly we needed to move on this, but felt that actually this is largely a culture issue, and it's been around custom and practice. It's the way things have always been done. And whilst you can tell people what to do, there's quite a lot of other things that need to happen in order to change that culture and produce sustained change that you can be confident of in the longer term. And that's things like the training, like sharing good practice. It's supervision, clinical supervision of people. So there's a number of factors that we've put in place. Dr. Uzerali and Dr. Chowdhury in particular, they do have regular sessions with our regional medical lead for the Thames Valley region. I don't know what conversations have happened between them, so they may have had a conversation about the report, but I don't know for sure, and it's something I can go back and check.
Isn't it up to the senior management at BPG, including you, to ensure that those instructions are being given to the doctors, given the poor quality of their reports to date, and the fact that the Home Office has relied in cases upon a lack of comment on the impact of detention in order to maintain detention? Isn't that something that you need as senior management to be ensuring is happening as a matter of urgency?
So absolutely, it's something that we need to ensure is happening. I would just take issue with the idea that my simply talking to them will make a huge difference to that. I think there's a number of things we need to do to change the way that Rule 35s are viewed and the custom and practice that has been in place at Gatwick.
But talking to them and instructing them to do what the form says is at least one thing you can do immediately without putting in place all the other things that will come further down the line, isn't it?
Well, it is, but I think the evidence that's been given and the conversation, the reports that have been written have pretty much explained to Dr. Uzerali and Dr. Chowdhury that the expectation is around that. So I don't know that I'm going to add an awful lot to that.
Can we look specifically at Rules 35.1 and Rule 35.2? Professor Bosworth did a sub-review of literature for the Shaw Review in 2016 and found that detention is harmful to those with vulnerabilities and mental illness. Were you aware of that at the time?
Professor Bosworth's report?
Yes.
No.
Shaw, in his review, was highly critical of the idea of managing serious mental illness in detention. He said it wasn't possible to meet good practice and described it as an affront to civilised values. Were you aware of that?
Not specifically. No, I don't think so.
The Shaw Review was also concerned about segregation appearing to be used as a default for those with serious mental health problems, and in particular without mental health care being provided to them, which he said was not consonant with detainees' welfare and may represent cruel and unusual punishment. Were you aware of that finding in the Shaw report?
So it's some time since I've read the Shaw report, and so I can't recall everything that was in it, but none of those things come as a surprise to me.
Yeah. Would you accept then that it's important for the Rule 35 safeguards to operate to ensure that those with mental illness are identified, not so that it can be managed in detention and healthcare provided to them, but so that the Home Office can promptly consider their continued detention, because otherwise they may remain in detention and open to having force used upon them, open to being segregated, which is likely to be damaging, and to potential deterioration of their mental health?
So, do I think that mental illness should be identified and reported? Yes, of course. I don't think it's quite as straightforward as that. Would it be so simple as that people arrived with a label stuck on them to tell you exactly what's wrong with them? Unfortunately, healthcare doesn't really work like that, and it can take some time to understand what's going on for people. It can take some time for them to open up and express their concerns, their vulnerabilities and their health needs. And in the meantime, we need to look after people. So our job is not only, it definitely is to do with these safeguards, and we take our responsibility for that seriously. But our role is much wider than that within healthcare, and it is to look after people. So we need to make sure we get the balance of that right. And if we focused too much on one or the other, then we're not meeting the needs of people effectively.
Rule 35(1) is a key statutory reporting mechanism for triggering a detention review in respect of someone who's likely to be injuriously affected by continued detention. It doesn't require actual harm, does it?
Yes, that's my understanding, yeah.
There's only been one Rule 35(1) report from September 2021 to January 2022, according to your witness statement. Sandra Calver, certainly in her evidence, had accepted that she had misunderstood the threshold for a Rule 35(1) report, and she and her staff were applying too high a threshold. Her evidence was that this misunderstanding had led to very few Rule 35(1)s at the time in 2017, and it appears there remain very few Rule 35(1)s being completed in Brookhouse. Would you agree?
Yes.
That was a failure at the time in 2017. She took some responsibility for, along with the Home Office. Would you agree with that?
I don't know whether she took responsibility.
In her evidence, she accepted that the failure in the safeguards, in that there were so few Rule 35(1) reports when there should have been more, was partly her responsibility along with the Home Office.
Okay.
Would you agree?
Yes.
Does senior management also bear some responsibility in the failure in the safeguards currently?
So yes, we are responsible for what goes on in the Gatwick Immigration Removal Centre.
The very low numbers, even currently, suggest that the safeguard continues to fail. Would you agree with that?
Well, I don't know, because I don't know what conditions people have come into Gatwick with, and that's something that we want to explore.
But of course it doesn't, Rule 35(1) doesn't require a condition, does it? It requires a likelihood of harm in detention.
And one might argue that anybody coming into detention has a likelihood of harm from being in detention.
I'd like to just look at a couple of examples, please, that come from the recent past. In some evidence from Teresa Schleicher from Medical Justice about some case studies that she had looked at is at her second witness statement at Annex 2, page 118. She set out a case of a detained person known as RMA, and he had a mental health appointment on the 11th of September 2021. So this would have been after PPG had taken over healthcare in Brookhouse. He disclosed feeling hopeless, anxious and having difficulties sleeping, but there was no Rule 35(1) report completed at that stage. Do you accept it should have been?
I don't know. With that level of information, I couldn't say. Like I say, I think pretty much anybody coming into detention would have trouble sleeping and feel anxious, and one could argue that that's detrimental to anybody entering detention.
On the 14th of September, he was still showing those symptoms, and he had also self-harmed a week beforehand by banging his head against the wall. No Rule 35(1) report was completed at that stage. Do you accept that at that stage it should have done?
Again, I don't know. With that level of detail, it's very difficult to make an assessment on that. Self-harm is interesting. People self-harm for a whole variety of reasons and not necessarily related to mental illness, but it does rather depend on how you define mental ill health. It is not good for your mental health to have control taken away from you and to feel powerless. And therefore, most people's mental health in that definition of it would deteriorate when coming into detention.
By the 21st of September, he was reporting auditory hallucinations. No mental health assessment was done on him. Do you accept that given the reporting of those symptoms, he should have had a mental health assessment.
Yes, I would expect a mental health assessment at that point.
The GP who saw him didn't complete a mental state examination. He should have done, shouldn't he?
He certainly should have undertaken some form of mental health examination, but GP mental health examination is very different from what a psychiatrist would undertake, and is obviously much briefer.
Yes, of course. He went on in November 2021 to undertake a period of food refusal. Again, no further examination was done in relation to his mental health. Should a period of food refusal have at least prompted consideration of a mental health assessment?
It would certainly, somebody who's undertaking food refusal should be seen by a doctor and try to understand the reasons behind the food refusal.
Yes, that doesn't seem to be happening in Brookhouse currently either, does it?
To be honest, I don't know the answer to that.
Medical Justice became involved and informed healthcare of their concerns on the 23rd of November. But again, no mental health assessment was carried out. At that stage, when an external body involving clinical expertise in this area is informing healthcare of concerns, that should have prompted some further exploration of his mental state, shouldn't it?
I would expect to, yes.
Medical Justice wrote to healthcare on the 2nd of December to raise concerns about his mental ill health and a diagnosis of PTSD. Would you agree that there seems to be here, from this case study, various different failures in the safeguards happening in terms of a lack of mental health assessment, a lack of consideration of Rule 35(1), and at least a not taking account of concerns raised by other medical professionals?
So, on face value of everything you've said, of course, there were points at which assessment could have undertaken to have made a difference. I don't know any of the circumstances surrounding this or any other factors relating to it. So, being painted a line in that direction, of course, the conclusion is there are points at which they could have intervened, but I don't know what else was going on.
He was only released from detention after litigation. Again, the Home Office hadn't had a chance to review his detention because the Rule 35 reports weren't being completed. Would you accept that?
Yes.
It seems then that deteriorating mental health in detention is being managed in detention, even though that was said to be poor psychiatric practice by as long ago as 2016 by the Shaw Review. Would you agree with that?
Can you just say that again? Sorry.
That deteriorating mental health appears to be being managed in detention, despite Shaw's criticism of that as being poor psychiatric practice as long ago as 2016. Do you agree? So it's not simply about enabling staff to manage and treat conditions in detention. It is about the importance of those safeguards notifying the Home Office in order to review detention, isn't it?
As I say, there's a balance to be had, isn't there, between those two elements of the care that we provide. We're largely commissioned to provide community equivalent healthcare in detained settings. There is no community equivalent of Rule 35, yes. Of course, and so that's an additional duty that exists in immigration removal centres that is not normal for general practice outside. And of course, we don't have the luxury, as you've rightly pointed out, of 45-minute, an hour-long appointments to undertake those assessments.
Sandra Calver in her evidence accepted that it's inappropriate, it would be inappropriate to use Part C instead of Rule 35(2) or Rule 35(1). Would you agree with that?
So I don't understand the Part C process well enough to be able to pass much comment on it. What I will say is that in my experience of working across secure environments, there's a lot of processes that kind of don't quite work. And one of the things I discover a lot when I'm travelling around sites is that people put in workarounds to make up for the fact that the systems don't work that well. And part of my role is to challenge those workarounds and to say you might be thinking that you're acting in the best interest of an individual, but actually what we've got to do is make the system work effectively as best we can, and that's part of the challenge that's going in now.
And the problem with Part C is, of course, that it doesn't, contrary to Rule 35, require the Home Office to review detention. So the statutory requirement is contained in Rule 35 and not in Part C. Do you think your staff understand that adequately?
So I didn't understand that myself until the last couple of days of the inquiry, so I can't speak for other people, but certainly I haven't had that level of understanding.
From Dr. Uzarali's evidence, it appears that he's still using Part C and not Rules 35(1) and 2. Do you agree, in the circumstances, that practice is inappropriate?
So I think people use processes to bypass the system when they find them effective, and that seems to indicate to me that there is something broken in the system of Rule 35 that people have been trying to find ways around.
But he should at the very least be doing both, shouldn't he? If there's a concern about a vulnerability or self-harm or a suicide attempt, suicidal ideation, or a deterioration in someone's mental health, he could put in a Part C, but he should also, in those circumstances, be using Rule 35, given their requirement of a review by the Home Office of Detention.
That's my understanding of the rules there. I think, again, from conversations over the years, when I haven't been particularly involved in immigration removal centres, I think Rule 35 has become kind of shorthand for discussion around torture.
Yes.
And the elements that you've been alluding to, Parts 1 and 2, I think have been a little lost along the way.
The vast majority of reports are Rule 35(3) reports, and it appears that Rule 35(2) isn't used at all.
Certainly not in Gatwick, no.
We know, in relation to Rule 35(2) from the Home Office figures, that there were no Rule 35(2) reports completed in Brookhouse in 2017. Indeed, there weren't any in 2016, 2018, 2019 or 2020 either. Your own figures from September 2021 to January 2022 also confirm no Rule 35(2) reports since PPG took over. That's of serious concern, isn't it?
It's of concern in light of the number of constant supervisions that have been happening during that period of time, yes. Yes,
and I mean, so in 2017 there were 60 incidents of self-harm. There were, in the relevant period, 195 new ACDTs open and 248 in total. Sandra Culver accepted that in the light of those figures there should have been significantly more of both types of report, Rule 35(1) and Rule 35(2). Do you agree?
One would assume so, yeah.
She said that nurses don't have a good understanding of Rule 35(2) and that there is a significant gap in their knowledge both then and now, and she accepted that that's a serious failing in the safeguard. Again, that's something of serious concern, isn't it?
Yeah, as I say, I think the Rule 35 process has become synonymous with looking for torture, so people have forgotten both Parts 1 and Part 2.
Were PPG aware of that when they took over the contract?
No.
Because the IMB report of 2021, which covered the period of January 2020 to December 2020, described the lack of any Rule 35(2) reports to be puzzling in the light of the scale of self-harm and suicide threats made during the latter part of 2020. And they said we cannot reconcile the evidence of frequent suicide ideation with there being absolutely no Rule 35(2) reports. You weren't aware of that at the time?
Not until more recently.
Your statistics that you set out at paragraph 131 of your first witness statement on ACDTs indicate that there were 73 opened, with 45 of those a constant watch for the period September 2021 to December 2021. Someone being on a constant watch indicates a high risk of suicide, would you agree?
Certainly a high risk of harm.
And as we've just established, there were no Rule 35(2) reports at all in that corresponding period. Again, that suggests a fundamental ongoing failure in the safeguard, doesn't it?
It does.
Doesn't that need urgently addressing?
I think we are addressing it, but as I say, whilst it's tempting to think that you can just dive in there and fix this problem that has been clearly endemic for the last 5 years at least, given the numbers you've just given me, it's tempting, but it's not possible. There's something that deeper that needs to happen, which is a cultural change programme. And I think it ties in together with some of the criticisms that I've read and I've heard about as part of this inquiry, with a culture of disbelief. So where you've got a culture that builds up, that essentially starts to think that people are just trying to game the system all the time, and therefore it becomes a conflict about whether Rule 35 should or shouldn't be done. You've got a problem there. Where we need to get to is an understanding that this is part of the safeguarding procedures to make sure that people are fit to be detained as best as it's possible for us to establish that as healthcare professionals. And that is not something that is easily, quickly fixed, either just by conversation or by writing policy. That there's something that needs more time. I think the other thing I'd like to just say about that is that it might feel like a long time between September and March, but when you take over a new service, it can take quite a long time to really get under the skin of that service and understand what's really going on the ground, rather than just have sort of documentation and numbers. That's been a little bit hampered by COVID because of the number of outbreaks and the limited access. But notwithstanding that, we have had quite a number of visits into the site. But as I said right at the very beginning, this inquiry has done us a huge favour in the sense of being able to really expose some of the issues that need attention from now on.
Yes, I mean, Dr. Uzerali confirmed in his evidence to the inquiry on the 14th of March, so over 2 weeks ago, that he's still not completing Rule 35-2 reports. And Sandra Calver gave evidence that she has tried to encourage the completion of Rule 35-2 reports with the introduction of her Rule 35-2 pathway, to no success, that GPs still aren't completing Rule 35-2 reports. Sandra Calver gave evidence a month ago today to the inquiry. Has anyone taken up this issue from senior management at PPG? Has anyone taken up this issue with Dr. Uzerali, Dr. Chowdhury or Sandra Calver as to what they're currently doing on the ground?
Yes, so there was a contract review meeting between the regional manager and the regional medical lead for that area, where the Rule 35-2 were discussed with Dr. Uzerali. They've reached out to me for further conversations with them, which I've not yet managed to undertake myself, but as I say, we've got this workshop in place. We were waiting there, and I do acknowledge the delay that you've pointed out, and that's a fair point, but we were waiting until we took over Heathrow so that we could have the two teams together, as I mentioned earlier.
Yes, I mean, your colleague, Mr. Wells, gave evidence yesterday that a review is due to take place on the 20th of April into the Rule 35 process, and that PPG are planning to develop its own pathway to ensure compliance with the rules. But he accepted that in the meantime, as we know Rule 35-2 reports are not being done, there's a risk of harm to detainees, isn't there?
There's always a risk of harm to detainees, but yes, I take your point.
And indeed, there's likely to be harm actually having been caused, because if people are on ACDTs, self-harming, their mental health deteriorating, that's actual harm having been caused by them remaining in detention in the absence of the safeguards working, isn't it?
Potentially. So not everybody that self-harms is mentally unwell or has a deteriorating mental health condition. And that might sound odd, but as I mentioned earlier, there's a number of reasons why people would self-harm. And it depends on where you want to put a threshold. As I mentioned earlier, everybody's mental health will deteriorate as a result of coming into detention.
Mr. Wells seemed to suggest that the reason that the risk of harm to vulnerable detainees was accepted by PPG and not being addressed immediately was that PPG didn't want to bring in a series of changes to working practice that can be confusing to staff. And he said he's discussed it with you. And he also said, I think we took a conscious decision that we wanted to ensure that we had a full and robust process and policy in place rather than just making an immediate snap decision to put something right. And he said, as I said, I think this is about a whole system approach review rather than just putting in place, for want of a better phrase, a sticking plaster over an issue. But isn't immediate action needed at least some immediate action needed to prevent harm coming to these vulnerable people who are currently in Brookhouse at the moment?
So I think there are mitigating actions being taken to look after people and to reduce that risk of harm, and that's the job of the healthcare department. So as mentioned earlier, the healthcare isn't only there to fulfil rules 34 and 35, they're there to deliver healthcare to people and to reduce risk and to manage health conditions, including mental health conditions, and there's a mental health team and a psychiatrist there to do just that. So whilst I appreciate the safeguards around Rule 35 are taking us some time to work through, that doesn't mean there's no action being taken to mitigate harm and risk.
Well, it's not a complicated matter to, at the very least, give an instruction to Sandra Calver and her staff that to refer anyone who is on a constant watch on an ACDT for a Rule 35-2 assessment and anyone who's on an ACDT at all for a Rule 35-1 assessment, is it? Couldn't that instruction be given to Sandra Calver?
So I think the instruction has been given that everybody who has an ACDT should have a mental health assessment so that we have an understanding of their mental health. And that may well lead on to a further assessment, but I appreciate there haven't been any Rule 35-2s done as a result of that yet.
Nor indeed, it seems really any Rule 35-1s recently.
Agreed.
A corresponding instruction could be given to Dr. Uzerali, couldn't it? That where someone's on an ACDT, he should consider a Rule 35-1 report, and where someone's on a constant watch, he should consider a Rule 35-2 report, couldn't there? Has that instruction been given to him?
No.
At least that would then cover the people you actually know about who appear to be deteriorating in detention by the fact that they're on an ACDT, wouldn't it?
That may be true. Again, I don't know who's on ACDTs or any of their conditions. So,
well, we know from Mr. Hewer's evidence this morning that there are 5 people on ACDTs, 2 of whom are on a constant watch. Has any consideration been given to getting them a Rule 35-1 or Rule 35-2 report?
I don't know, but that's something I can go and find out.
Yes, please, and report back to us. Because given those numbers, given that the numbers in Brookhouse are so low at the moment, of 5 reports, it would be easy enough to arrange those assessments speedily, wouldn't it?
I would imagine so if they're required, yes.
You could also, couldn't you, give an immediate, simple instruction to Dr. Uzerali that if he completes a Part C, if he finds it necessary to complete a Part C, his workaround, as you've put it, in relation to a vulnerable detainee's deterioration, their self-harm, a suicide attempt, or any other concern, he should also, at that time, complete either a Rule 35-1 report at least, or, if appropriate, a Rule 35-2 report. And
that will be a conversation, I'm sure, that we will have as part of that pathway workshop in April.
Well, shouldn't that be happening now?
Well, I think it would be lovely, and I dare say that I would have had a lot easier time in this particular conversation had we just written a policy and handed it to Gatwick. I just take issue with the fact that it would be effective, because I know from experience that simply issuing those instructions to sites, it's not effective in changing customer practice, and it's certainly not effective in changing the quality of the report and the likely effectiveness of that report in actually ending detention. And so that's why we have chosen to go down a much deeper route of looking at culture change and challenging custom and practice in order to actually fix the issue.
Yes, again, I'm sure that's laudable, and will bring about, or will hopefully at least begin to bring about, the types of enduring change. But what about the people who are sitting on a constant watch on ACDT today in Brookhouse?
So I don't know anything about them, but as I say, it's something I can take back and I can find out what's been happening for them, whether they've actually had a mental health assessment and whether they should be having an assessment under Rule 35. But sat here at the moment, I don't know.
Are you aware the IMB report of 2021 recommended to NHS England that it should carry out a systematic and ongoing review of vulnerable detainees to monitor the effect of continued detention on their well-being?
Yes.
And do you know if that's been done by NHS England?
Yes, I believe there was a visit by a safeguarding visit by NHS England. I can't remember the date off the top of my head.
Would you be able to find out?
We can find that, and we have a report from them and a series of recommendations that have been made.
And would you be able to provide those to the inquiry?
Yes, of course.
Thank you. In relation to use of force, Are you aware also that the IMB 2021 report expressed concerns about the high incidence of use of force being used to deal with self-harm?
Yes.
Sandra Calver confirmed in her evidence that force is used to relocate people to E-Wing and on E-Wing to deal with those at risk of self-harm or presenting with actual self-harm. Are you aware that that's still currently happening in Brookhouse?
I don't know.
Would you agree that use of force risks exacerbating and damaging further the mental health of vulnerable detainees and shouldn't happen unless it's to prevent a risk to life?
I would agree with that. Certainly does nothing to improve relationships, that's
No,
for sure.
and it should be a last resort.
It should.
So it's a concern if it is still being used as effectively a custodial risk management tool to respond routinely to self-harm, isn't it?
Yeah.
Mr. Wells accepted that that's a concern and warranted further exploration. Is that something that the senior management at PPG are going to do, to look into the resort to use of force by self-harm, the healthcare's role in not raising concerns or contraindications in relation to that?
So I think there's a couple of points in there. So I hadn't been previously aware, I hadn't been aware until recently about the use of force for self-harm incidents. So I need to understand in more detail whether that is custom and practice now and what is being done about that. There was a second part that you just asked me, which was, I can't now remember.
That there should be exploration by PPG at a senior management level that it appears that healthcare staff are not raising concerns or contraindications to the use of force, such that then force is being used routinely to respond to self-harm.
Yeah, so I think we've recognised that not just in immigration removal, but across the secure states, there has been no training in healthcare roles and responsibilities in use of force incidents. And that's a failing, I think, across the whole system. It's not peculiar to us as a provider. Our Director of Nursing and Quality feels very strongly about this because nurses are often put in a very challenging position of being a single voice in a highly charged situation, and often they're unsure of their role and responsibility. And so we've just piloted a training course, I think in Yorkshire is where it's been piloted, to look at just this, to support staff in being able to raise concerns, to understand what they need to do and what their responsibilities are, and that's being rolled out to Gatwick. Off the top of my head, I don't know what date they're receiving that. Again, that's something we can get to you if that would be helpful.
Thank you. Yes, it would. In relation to D1914, we heard that in 2017 in May, Dr. Uzarali wrote what's been referred to as a fitness to fly letter, and he stated in that letter, the above detainee is fit to fly and fit for detention. He will need a medical escort due to the nature of his medical condition. I'm happy for reasonable force to be used, CNR, in order to facilitate the removal. Is PPG aware of that practice of GPs providing such letters currently?
So, of the use of force bit, I wasn't aware of that until this inquiry. The fitness to fly, I was aware of. We've certainly come across this before when we had Campsfield House, and also at Hunter Combe, which is a foreign national prison where people can be deported directly from Hunter Combe. We put in place a new policy after some discussion and some expert support around fitness to fly, to just shift it very slightly away from saying, yes, this person is fit to fly, to we know of no reason why this person is not fit to fly.
Yes, because the two are different.
They're very different, and it's a level of responsibility that I don't think we can take as a healthcare provider, and it's not right that we do. I have to say it was against some pushback from the Home Office who wanted fit to fly letters, but we managed to stick to our guns, and that's certainly some of the work that we'll be undertaking with Gatwick to get a shift in thinking away from saying this person is fit to fly.
And the expression of a approval of a use of force is of serious concern if that's continuing, isn't it?
Yes, again, I think highlighting what people's medical needs are or risks associated with use of force is entirely appropriate. To say somebody is fit to have use of force is something quite different.
Yes, and completely inappropriate.
I would agree.
And is that something that's going to be raised or is being raised with Dr. Uzarali and Dr. Chowdhury, who appear to be undertaking that practice?
Yes.
In relation to DSO 04/2020 on mental vulnerability, are you aware that the policy background to the development of this DSO was some litigation in the cases of VC and MDA, where in those cases on 2 occasions in 2018 and 2019, the arrangements in the IRC discriminated against people who suffer from serious mental illnesses or lack capacity because they can't access independent assistance to support them to make representations about their detention or their medical treatment. Were you aware of the background to the introduction of that DSO?
No, I wasn't.
The DSO has been the subject of some criticism, for example, from medical justice for not addressing the issue that a lack of independent assistance to support those people means that discrimination may still occur. It depends, the DSO depends upon wing officers and healthcare recognising concerns about lack of mental capacity, the mental condition being assessed and recognised, and the detained person engaging, and there's no provision in the DSO for any independent advocacy for the detained person. Would you agree that that's still a concern? If there's a lack of independent advocacy for those who have serious mental illness or who may lack capacity?
Yes, I think it is a concern.
There's nothing about independent advocacy in your witness statement. Did you know about this gap in the system?
No, I think it's a simple answer. Now you say it, it makes complete sense, but at the time I
Yes.
wrote the statement, it wasn't something that was on my mind.
It seems from the evidence the inquiry's heard that there doesn't seem to be a routine consideration of mental capacity in relation to those who have vulnerabilities or mental health issues. Again, if that's right, that's of concern, isn't it?
The mental capacity is a dynamic thing. There isn't a sort of single point where you say this person does or doesn't have mental capacity except in extreme circumstances. So that's something I would expect to be happening on a regular basis as a dynamic assessment of somebody.
And if it isn't, it's a concern.
It would be a concern. I have no evidence either way, except I can't be sure. I've heard of a case recently where they'd assessed mental capacity, but I can't be 100% sure it was Gatwick.
Are there plans for PPG to commission any independent advocacy service into Brookhouse?
Not that I know of, but it's certainly something we can look at with our commissioners.
Yes. And so would you plan to do that?
I'll raise it with our regional manager to talk to our commissioning colleagues around that.
Just finally then, at paragraph 84 of your statement, you mention potential future problems with supporting independent doctor reviews whilst maintaining healthcare provision due to a lack of space and resources. Do you agree that detained people should be facilitated to get medical assessments needed in respect of their detention and to the extent relevant for their immigration applications?
So I think if I can just widen that ever so slightly, because there is a tension that is inherent in the system that we have in place at the moment between the role of provision of healthcare and the assessment of somebody's fitness to remain in detention. And that can create, and I think Dr. Israeli did discuss this a little in his evidence, around that detention, particularly if the doctor disagrees with an individual about their fitness for detention, that can have a damaging impact on the relationship. I would prefer to be in a position where we were providing healthcare and other people were assessing fitness for detention as a separate process, but that's not the position that we're in at the moment. And so we are, as discussed, working on how we make the system work effectively. But independent advocacy will play a role in that without a doubt. The space issues are very real in Gatwick. I don't know how many people in the room have been able to visit healthcare there, but there are 4 rooms, one of which is a pharmacy, one is an office, and 2 clinical rooms. So there is a tiny amount of space in which to deliver any kind of healthcare. And so it's a constant tension, I think, and a balance between the various different priorities.
you'd accept that a detained person has a right to access the necessary evidence to advance their immigration case in detention or to challenge their detention.
And that right is written into law, I believe. So
And restrictions placed upon their access to independent experts can impair their right of access to legal remedies.
I don't think there's any intent to restrict that. It's a simple practical issue about space available in order to provide that.
And so what steps are PPG taking in order to address those problems?
Again, discussion with our Serco colleagues. One of the similarities between an immigration removal centre and a prison is the fact that providing healthcare in these environments, we're not in total control of our environment, and a great deal of partnership working is required in order to make things work effectively. So discussion with Serco about whether other spaces are available, whether we can expand some of the clinical space in order to be able to provide more services. And certainly I know there's been discussion about the dental suite, for example, which I believe is still currently a toilet, but is going to be converted at some stage. So they are trying to get creative about finding space in order to deliver healthcare. But those are conversations, and as you heard from Serco earlier, there is a limit to what they can do to the built environment.
Yes, thank you. Chair, I don't have any further questions for this witness.
Thank you very much, Ms Simcock. Dr Bromley, it's not a question as such, it's just really to reiterate what Ms Simcock has said around, I think, as you will appreciate from the question that I asked yesterday of Mr Wells, I would like to understand fully, and obviously you've explained something around the rationale for delaying the review of Rule 35, but I think, as Ms Simcock said, and as my question was yesterday, I want to fully understand what is happening at the moment for those people who are on constant watches. So I would be grateful if you could provide the inquiry with some further information about that.
Yeah.
Thank you very much.
Chair, I understand that due to a technical issue at the beginning of the broadcast, the witness's name was missed. So I just wonder, could you please, again, state your full name for the inquiry, please?
That's a very nice, easy question. Thank you. Dr Sarah Bromley.
Thank you. Thank you, Dr Bromley.
Thank you very much for coming this afternoon. I very much appreciate your evidence.
Thank you.
Thank you, Dr Bromley.
10 o'clock on Monday for the evidence of Mr Riley.
Thank you very much. Thank you.